Alright, so in this video, we're going to go over a basic movement and exercise routine that we can use for our acute lower back pain patients. Now, let's start with some basic context. And I think the key thing to realize and keep in mind here is that with pain and injury, movement, particularly movement in the form of specific exercise prescription, is a really critical part of patient care. Remember, through biological processes like mechanotransduction, movement and exercise allows us to essentially communicate with the body. From a physiological perspective, movement can be a powerful tool to do things like reduce swelling and inflammation, control pain, and to guide tissue healing. But movement also has a powerful cognitive and psychological effect with acute back pain as well. And this is really where we can help patients understand the meaning of pain, to understand how hurt doesn't always equate to harm, and how sometimes we need to work into the symptoms as part of the recovery and rehabilitation process. But beyond these basic physiological and cognitive behavioral principles, we can also think of this from a functional perspective. Here, what we're really trying to do with our initial treatment and exercise prescription for our lower back pain patients is to develop and regain tolerance to basic spinal motion. So I like to think of it this way. A healthy lumbar spine needs to be able to flex, extend, laterally bend, and rotate. And if the lower back can't access and can't access and perform these basic motions, it's either going to hurt all day or movement is going to be significantly altered as the brain has to find alternate movement strategies to avoid these painful movements in painful positions. Now, of course, these principles are not exclusive to the lumbar spine. These are established principles that apply to the body as a whole. In previous articles and videos, I've even talked about and reviewed some of the basic exercises and movement sequences that I use when treating pain and injury in other areas of the body, like the knee, the hip, or the ankle. But the problem we have with lower back pain is applying these principles. Remember, we're using movement and exercise to communicate with the body, but for this to happen, the movement needs to specifically occur at the affected joint or at the specific injured tissue. And when it comes to acute lower back pain, injury primarily occurs at the joint level. For example, think of the vast majority of lower back injuries. These involve things like the intervertebral disc, the facet joint and the facet capsule, or the deep intersegmental muscles or ligaments. So to be effective and to communicate with this affected area and with the affected tissue with most common low back injuries, the movement needs to be directed at the joint level. Now, this is easier with other joints like a knee or a hip or ankle, but the spine is not like other areas in that it is not a single joint system. It's a series of individual joints that coexist to form a movable column. So the challenge becomes, how do we create a local stimulus at the joint level, not just as the back in general? Here I would also argue that it is not only critical, but it is not typically considered or done. For example, think of traditional lower back stretches like a child's pose or cobra or a knee to chest exercise, or even exercises like a plank or a bridge or bird dog. With these exercises, ask yourself, which joints are we actually targeting or influencing here? The fact is, we just don't really know. Furthermore, given that muscle tightness and spasm often accompanies injury, it is extremely unlikely that the affected joints are getting the stimulus they need with these traditional exercises. Now, the second key thing we must consider is that these movements and exercises need to be safe, and we need to be capable of modifying the stimulus intensity. Yes, we're trying to create and direct movement at the lumbar joints, but we need to respect the fact that there's symptoms, and we need to respect the fact that we want to avoid any potential flare-ups of a patient's condition. So to do this, to create motion that is targeted at the individual lumbar joints, and to do so in a way that we can modify the range of motion and the intensity we are using, we're going to base our movement and exercise prescription on pelvic tilts. Now, I know what you're thinking here. You've seen pelvic tilts before, but you haven't seen them or used them in the way I'm going to talk about here. So before we get into the exercises, let's just take one final moment and talk about why these movements and these exercises are so effective for acute lower back pain. Remember, the spine is not a joint, but it's a series of joints. And if we follow these joints down, we know that they sit atop the sacrum. In other words, the sacrum forms the base of support or the support platform for the lumbar spine itself. And as a result of this anatomical relationship, movement of the pelvis will also create motion at the lumbar spine, specifically at the lumbar intersegmental joints in a bottom-up sequence. Also note that these are not static stretches, they're active movements that utilize the deep muscles surrounding the spine. Again, this will help to target motion at the individual joint segments, but these contract-relax cycles can also be helpful with modulating pain and working to pump and flush swelling and inflammatory chemicals away from the area. Furthermore, being active movements, we can control the force and intensity of the motion much better, and we can control the ranges used so we can really make sure we're not overloading the patient and keep the exercises and the symptoms at a safe and tolerated level. Lastly, at least in the initial stages of our treatment, these exercises are going to be performed in non-weight-bearing postures. This again minimizes the force on the spine itself, making the load safer in the initial stages of care. So what I'm going to do from here is review the exercises themselves. Once I've gone through all of the exercises, I'll wrap up the video by talking about key programming and progression criteria. That's where we're going to talk about things like how many sets and reps, optimal exercise frequency, and what's okay and not okay as far as symptoms that the patient may experience during the exercise. I'll also cover when you know you're ready to progress onto the next level of care. And just as one last FYI, if you are a My Rehab Connection subscriber and you use our exercise prescription software, you can find all of these exercises in our exercise library. You can either search for the exercises by name in the exercise library itself, or you can find this sequence in the exercise group section under the title Basic Lumbar Mobility Sequence, Pain Mobility Focus. Okay, let's take a look at the exercises. So the first exercise we're going to look at is an anterior-posterior pelvic tilt, but performed in a supine position. So here we're simply going to lay on our back, and I'm going to have my feet flat and my knees up, just to help create some, or to kind of reduce tension around the hips with this position. If I need to, I can certainly support my head with, a pillow or a yoga block as needed. Now from here, I'm simply going to create a rolling motion through my pelvis. I'm going to kind of roll into a posterior pelvic tilt position. Here I'm essentially pulling the front of my pelvis, my iliac crest, up towards my ribs. And this is going to create a bending motion. It's going to create flexion through the lumbar spine. What we are essentially trying to instruct our patients to do is to tuck their tailbone underneath their hips. And so they're going to feel as they do this, their lower back push into the floor. We're going to have them hold this position just for 1 to 2 seconds. So there's a distinct pause. And then they're going to perform an anterior tilt. Here they're simply going to roll their hips and their pelvis forward. This is going to create extension of the lumbar spine, and it's going to start to lift or arch that spine up off the floor. Again, they're going to hold just for a small, distinct 1 to 2 second pause, and they're going to simply perform 10 slow oscillations back and forth. Now, a couple of key things here is this is not a big motion. Remember, the key is we're trying to create focused motion at the lumbar joints themselves. And so we're not trying to kind of lift really high up into the bridge, and we're certainly not trying to, when we arch our back, lift our whole spine. We want to try to keep this motion isolated to the lumbar spine itself. And lastly, as I'll talk about a little bit more in the second half of the video, when we do this, the idea is we want to move as far as possible, but we're not trying to move into pain. So we can limit the range that we're using as needed based on symptoms. The idea here would be some achy, mild symptoms are perfectly acceptable. This helps us to influence the tissue and clear the range, but these are not no pain, no gain exercises. So again, it's just going to be back and forth, going into a posterior pelvic tilt, lower back pushes down, joints open, going into an anterior pelvic tilt. We're lifting the lower back off the ground into lumbar extension. Slow oscillating motions back and forth. Move as far as we can, but we're going to keep the motion to symptom tolerance as needed. All right, so we typically think of pelvic tilts as being a front to back or anterior posterior direction. But remember, the spine needs to bend laterally as well. So we can also perform lateral pelvic tilts. So the first thing we'll show is in a supine position, we're going to be laying on our back, knees bent, feet flat on the floor to keep the hips relaxed. Now from here, I'm simply going to bend laterally. So I'm going to pull my right hip and pelvis up towards my lower rib. So here, I'm simply going to rotate laterally. I'm trying to pull my right hip up towards my right lower ribs. I'm trying to close down this angle. As this angle closes down, the left or opposite side is going to open. Holding 1 to 2 seconds, I'm then going to rotate the other way. I'm pulling my left hip up towards my left lower rib. Left side closes, right side opens. And I'm simply going to perform 10 slow, deliberate repetitions back and forth. Again, I'm trying to create motion at the lumbar spine. I want to keep upper back and shoulders relaxed. I want to keep legs and hips relaxed. I'm using the muscles, particularly the lateral trunk muscles, to create the motion. And I'm trying to keep this motion isolated through the lumbar spine and through the pelvis. I'm going to perform 10 slow, deliberate repetitions. Remember, some mild achy symptoms are perfectly acceptable, but we can limit the intensity and the range that we're using based on symptom tolerance. In addition to performing these anterior-posterior pelvic tilts from a supine position, as soon as is tolerated, we're going to also try to do this from a quadruped position. So again, the idea, we're just going to establish a basic hands and knees position. Now from here, I'm going to perform an anterior tilt. I'm just going to slightly rock my pelvis forward. Again, I'm going to go as far as I can, but not pushing into pain. This is the lumbar joints are moving into extension. Hold 1 to 2 seconds, and then I'm going to simply perform a posterior pelvic tilt, moving into lumbar flexion, again, as far as I can go, but I'm not pushing into pain or discomfort. I'm going to simply perform 10 slow repetitions back and forth. Again, some achy, tight symptoms are perfectly tolerable, but I'll limit the range as needed based on symptoms. Now, a couple things to keep in mind here is that oftentimes patients will think of this as a typical yoga cat-camel thing. And that is not what we're really trying to do here. We want the motion to be very focused at the lumbar spine itself. So I really do need to make sure that they're rolling through their hips and the pelvis to influence the spine. What I really don't want to see is that whole back or whole spine come up. Not that this is a negative, but it's really creating motion more through the thoracic spine, and it will not be creating individualized segmental motion through the lumbar spine itself. So we do really need to kind of keep that in mind. Now, the other thing to keep in mind, and it's good to kind of mention this with patients, is when we're doing this from our supine position, we do have the floor there. The floor is nice because it allows us a target. We can push our lower back into and off of the floor, but it does limit motion. So from this hands and knees position, I do really like this as it allows us to get more motion through the lumbar spine, but oftentimes this will be a little bit more symptomatic for those acute back pain patients. And also, like I just mentioned a moment ago, we do need to make sure from this quadruped position that we're keeping the motion at the lumbar spine itself and not pushing up and down through the middle back and through the thoracic spine. So again, it's going to be slight anterior tilt forward, creating lumbar extension. Hold 1 to 2 seconds, and then I'm going to rotate in the opposite direction. My spine and my tailbone are getting longer to create lumbar flexion. Slow back and forth, oscillating motions. 10 slow repetitions, moving as far as I can, but limiting the range as needed based on symptom tolerance. Now, the fourth exercise I like to, as much as possible, include in this movement exercise sequence is to perform these lateral pelvic tilts, but now from a hands and knees position. So I'm simply going to get in a hands and knees or quadruped position. Now from here, what I'm going to do is try to kind of create a lateral bending motion. I'm going to pull my right hip up towards my right lower rib. This is going to close down the right. It's going to open up the left. Hold 1 to 2 seconds, and I'm going to tilt back to the opposite direction. I'm closing down the left, opening the right. Just as we've talked about with the other exercises, I'm going to perform 10 slow, deliberate repetitions back and forth. I'm going to move as far as I can into each right and left lateral bent position, but I'm going to limit the intensity and the range that I'm using as needed based on symptom tolerance. Now, a couple really key things to point out here with this quadruped position is when we are doing these lateral tilts from the supine position on our back, the floor really does limit any compensatory motion. As soon as we move to this hands and knees position, there can be a tendency to kind of move all over. We can rock shoulders back and forth. And oftentimes what patients will do is try to tilt or slide their hips and their pelvis side to side. But we want to make sure we're creating more of a lateral bend. So it's often helpful here to think about there's a sort of a steel pole going straight down through our tailbone. And this allows us to rotate around the pole, but not push side to side through the pole. Sometimes it can also be helpful to visualize or kind of think about trying to keep the sacrum itself in line with the head. We want to keep it lined up so the bend comes through the lumbar spine as opposed to a tilting or shifting laterally through the hips themselves. Again, 10 slow, deliberate repetitions back and forth. I'm going to really try to focus on using my muscles of the lumbar spine in order to isolate that motion through the intersegmental joints themselves, keeping the motion focused. Remember, it's not a big movement. It's much more about quality than quantity. So now that we've gone over the program itself, let's go over the programming and progression criteria. First, as I briefly mentioned when reviewing the exercises themselves, the key with these motions is to move to symptom tolerance. In other words, we want to move as far as possible into each direction, but we're not trying to force the spine into painful positions. It's about trying to restore basic movement tolerance, but it's not a no pain, no gain scenario. Also keep in mind that the motions don't need to be symmetrical. And what I mean by this is with our anterior posterior pelvic tilts, the motions may need to be biased initially towards either flexion or extension, or during the lateral pelvic tilts, the motion may need to be biased towards the right or left side. We also need to be clear about how we explain these exercises to our patients. Remember, with a really painful or acute lower back, some patients will be very hesitant or even fearful of moving into some of these positions, especially if these movements create or reproduce some of their symptoms. Here, it can be helpful to point out to patients that these are all gentle, non-weight bearing exercises. And what this essentially means is that any symptoms that they may experience, at least if we're keeping the movements to symptom tolerance, as we just discussed, will more likely be the result of tissue inflammation or tissue hypersensitivity as opposed to further tissue damage or injury. As far as programming, the typical prescription is going to be that we will perform each of these movements for 10 slow, deliberate repetitions. And then we're going to repeat this every few hours. So the idea here is we're trying to create a light, easy, controllable stimulus, but to provide this stimulus on a very regular basis through the day. The other thing to point out here is that although I like all 4 of these movements as a full routine, as they cover all of the basic fundamental motions of the lumbar spine, it doesn't mean that we have to prescribe all 4 of these movements at once. Depending on the patient and how sensitive their lower back is, we can start with 1 or 2 of the movements and then add the other movements as treatment progresses and their tolerance and their confidence and trust in the movements improve. Now, finally, let's talk about progression criteria. Remember, from a big picture perspective, the primary objective is to build and restore tolerance to these basic fundamental lumbar motions. In other words, we need the lumbar joints to be able to flex, extend, and laterally bend, at least from a non-weight bearing position without hurting. So what we're essentially looking for is the patient is able to access and tolerate end range positions without pain. Now, just to clarify here, that doesn't necessarily mean the motion needs to be completely symptom-free. For example, if the patient has some very mild symptoms, but these do not limit their range of motion, then that to me is considered access to end range. And when this is the case, we are typically ready to progress them on to the next phase of care and the next exercise sequence, which in this case would typically be moving from a pain tolerance focus to one that's focusing more on control and mobility of the lumbar spine.